All right, let's talk about one of the biggest paradoxes in modern medicine, the hidden price of surviving cancer. You see, our treatments are getting better and better, which is fantastic news. But with that success comes a new, massive challenge, managing the lifelong consequences of the very cures that save the patient. So, let's dive in. 16.9 million. Let that number sink in for a second. That's how many cancer survivors there are in the United States alone. I mean, that's a monumental victory, right? It's proof that all the advances in chemotherapy, radiation, and transplantation are working. But behind that incredible number is a much more complicated story that we're just starting to grapple with. So, what is that hidden cost? Well, it turns out the very treatments that are so good at killing cancer can also leave this lasting, sort of iatrogenic footprint on the body's delicate hormone and metabolic systems. And we're not talking about the acute side effects during treatment. No, this is about chronic health conditions that can pop up years, sometimes even decades, after a patient is declared cancer-free. So here's how we're going to break it all down. First, we'll frame this whole new challenge in survivorship care. Then, we'll get into the specifics of three major treatments: chemotherapy, radiation, and hematopoietic stem cell transplants. From there, we'll navigate the really tricky clinical dilemma of hormone replacement. And finally, we'll wrap up with a call for a totally new approach: proactive surveillance. You know, for decades, the goal was simple: just keep people alive. And that made perfect sense. But now, with literally millions of people living long, full lives after their diagnosis, our focus has to shift. We're now in the business of managing chronic, treatment-induced diseases. The acute fight is over, but it's been replaced by a lifelong health journey. So let's start with chemo's metabolic footprint. These drugs are absolute powerhouses against cancer. But the thing is, they're not surgical strikes. They're more like cluster bombs. They can't perfectly tell the difference between a cancer cell and a healthy one, and that collateral damage can seriously disrupt the body's entire metabolic balance for good. And one of the biggest results of that disruption is what we call metabolic syndrome. Now, what's really staggering is just how common this is. We're seeing it in anywhere from 15% to a whopping 65% in certain groups of survivors. This is a huge deal because it puts them at a much higher risk for heart attacks, stroke, and type 2 diabetes, long after the cancer is a distant memory. Okay, so who's most at risk here? Well, the data points to a few key things. Some of it is what you'd expect, right? Being older, having diabetes or obesity to begin with. But what's really telling is that we see a much bigger impact on women, particularly breast cancer survivors. And this is critical. The specific chemo drugs they received play a massive role. And if you look here, you can see how it works. Different drugs inflict different kinds of damage. You've got your anthracyclines and platinum compounds, which basically cause widespread insulin resistance. Anti-metabolites go after the cell's power plants, the mitochondria. And taxanes just ramp up inflammation. The common thread here is a multi-front assault on how the body manages sugar and fat. But chemo isn't the only culprit. Even a localized treatment like radiation can land a devastating blow. See, when the radiation field has to pass through the head or neck area, it can cause this slow, progressive, and often silent damage to the pituitary gland, the body's master controller for the entire endocrine system. And the crucial thing to understand is that this damage is not random at all. It's dose-dependent and it's predictable. The growth hormone axis is the most fragile. It can get knocked out with a dose as low as 18 gray. Once you get up past 30 gray, you start seeing failures across the board in the reproductive hormones, thyroid hormones, and even the stress hormone axis. It's like a domino effect. And here is the single most important takeaway for long-term care. The damage is a slow burn. It's cumulative and it's delayed. Just look at this. The rate of hypopituitarism can almost double between year 5 and year 10 post-treatment. A patient can look perfectly healthy for years, and then a decade later, their system starts to fail. This is why you can never take your eye off the ball with these survivors. Now, what happens when you take the insults from both chemo and radiation, and then you add a powerful, brand new immune system to the mix? Well, that's what happens in hematopoietic stem cell transplantation, or HSCT. And this aggressive therapy, well, it often comes with the heaviest burden of all when it comes to late endocrine problems. And a huge driver of these problems is something called graft versus host disease, or GVHD. Basically, the new donor cells start attacking the patient's own body. From an endocrinologist's point of view, GVHD is the perfect storm. The disease itself causes massive inflammation, but the real trouble comes from the treatment. high-dose, long-term steroids that just wreak havoc on the entire endocrine system. And the consequences of that chaos are just widespread. In kids, you see profound growth failure. Puberty gets delayed or just stops in its tracks. He sees severe osteoporosis. On top of all that, the steroids themselves can give patients iatrogenic Cushing syndrome, send their blood sugar through the roof, and even cause full-blown diabetes. It's a real mess. But the risk isn't the same for everybody. It turns out that timing is everything. A patient's age when they get the transplant is a huge predictor of what happens later. Take a look. If a transplant happens before puberty, the risk of some of these issues is lower. But during puberty, the risk of hypogonadism more than doubles, and the risk of severe osteoporosis goes up 5-fold. It's this unique window of extreme vulnerability for their reproductive and skeletal systems. Okay, so when these hormone deficiencies happen, the solution seems obvious, right? Just replace the missing hormones. But in a cancer survivor, that simple solution becomes one of the most difficult, high-stakes decisions a clinician can make. It's this incredibly delicate balancing act between quality of life and oncologic safety. And this is the core of the problem right here. On the one hand, hormone replacement therapy, or HRT, can be life-changing. It can get rid of debilitating hot flashes, it protects bone density, it helps with so many symptoms. But, and this is a massive but, if that patient survived a hormone-sensitive cancer, you're potentially pouring fuel on any dormant cancer cells that might be lingering. You risk waking them up and triggering a recurrence. And this isn't just a theoretical word. The risk is very, very real. A landmark study called the HABITS trial actually had to be stopped early. Why? Because they found that breast cancer survivors on HRT had more than a 3 times greater risk of their cancer coming back. A finding like that just changes the entire conversation and really underscores how serious this decision is. Now, that doesn't mean HRT is completely off the table, but it does mean we have to be incredibly strategic. The approach now is to try everything else first, all the non-hormonal options. If you absolutely have to use systemic HRT, you go for transdermal patches or gels to lower the risk of blood clots. And the absolute golden rule is lowest effective dose for the shortest possible time. And whenever you can, if it's a local problem, use a local treatment. So when you put all of these pieces together, it becomes crystal clear that our old model of survivorship care just isn't working anymore. The sheer number of survivors and the complexity of all these late effects means we have to make a fundamental shift from just reacting to problems to proactively looking for them for the rest of their lives. This really requires a paradigm shift. First off, we have to start thinking of cancer therapy itself as a major risk factor for chronic disease, right up there with smoking. That means we have to screen survivors systematically based on their specific treatment history. It means we need to get baseline endocrine function before we even start these therapies. And yes, it absolutely means committing to lifelong surveillance, because for these patients, the risk never truly goes away. And really, this is the question we need to be asking ourselves. It's not enough to just cure the cancer anymore. We've gotten really good at that. As millions more people join the ranks of survivors, the next great frontier in oncology is mastering the long-term consequences of our own success. So how do we build a system of care that not only celebrates survival, but actively preserves health and quality of life for the entire journey that comes after?